who was here for Sharon's talk on AFib? Okay. Wow. Okay. Everybody. So this is going to be really good to have a follow-up because this is just another type of arrhythmia. But before I get started, I heard Linda talking in the back, and I said, I'm going to quiz you guys because supra-ventricular tachycardia is Latin. A lot of this has Latin meaning to it. So can anyone, she told people that were taking the stretching class this morning. What does supra-ventricular mean? Supra is above ventricles. And then tachy, does anyone know what tachy is?
That means
Besides, so tacky. It's
You're right. I had it in her email.
what?
it's to know now.
Fast. Right.
Okay.
So that's exactly what it is.
Don't now. Somebody else did.
Supra-ventricular tachycardia, or SVT. So let and that meant you. Oh, okay.
Right. Side. You're looking at a person, the right or left.
It's your right side. Yes. Okay, so then the second part of the electrical system is the AV node, or the atrioventricular node. Okay, so we got the AV node, the SA node up in the right atrium. So the AV node, it's located between the atria and the ventricles, and it acts as a gateway for electrical signals. So it kind of delays that signal to allow the atrial to completely fill with blood. And then for the, it then goes down to the ventricles for the ventricles then to contract. So the AV node is really important for that, for the electrical system to go from the SA kind of through the atria to the AV node, where it's a little bit delayed for the filling of the atrium. It's really, really important. Yes, that's the AV node. Yeah. And then the next is the bundle of His. And that's a pathway that conducts the electrical signal from the AV node down to the ventricles. So it's just this little area. Where's my, there we go. It's just that little area, the bundle of His. And then the next thing is the bundle branches. So that the bundle of His kind of branches off into two different branches because one goes to the right ventricle and one goes to the left ventricle. And remember, these are just electrical pathways that's carrying that signal to then tell the ventricles, contract, contract, okay? Is everyone with me still so far? And then we have the Purkinje fibers. And these fibers spread the electrical signal throughout the ventricular muscle, causing them to contract and pump blood to the lungs and the body. Any questions on that so far? Does it make sense? I don't know. Good question. Who's Purkinje? I bet that's somebody. So tell me, who had a basic knowledge of kind of the electrical system? Maybe not knowing the names, but you kind of just from here. Yeah. Because, you know, you kind of think about the heart and, you know, how important of a pump it is, but the pump ain't jack without the electricity to make it go, right?
Is it the same type of electricity that exists over everywhere?
Well, it's not like
Or 10 volt?
electricity. No, it's not like a 10 volt. What I find, what
2 volt.
though they do use electricity to stop the heart and to get it going. But the idea of that is it's eliminating any, well, anyway, I'm getting way ahead of myself. What I do want to say is when you're pregnant and that embryo, the very first cells that are developed are these little tiny pacer cells. And that's why you can hear a heartbeat at like 6 weeks old. It's the pacer cells, which is the SA node. It's the first thing that's developed, which I love that. Okay, just a little side note there.
There's two electrical systems, actually, the heart and then and the brain. Brain first and then the heart is a new electrical system in a way.
The heart is its own electrical system through the SA node. Are you talking about the synapses between? Yeah, that's something different.
Is it generated in the nervous system, this electricity?
Well, you guys are getting into the weeds. I may be calling on,
It's so
our,
fascinating.
it is fascinating. It is fascinating. Okay. Who has had an EKG or ECG, right? And so let's try to figure out electrically what's happening in the heart and what it looks like on paper. So we have P waves, and the P waves represent atrial contraction. So on that EKG, those little bumps right there, or look at here, that's the P wave. So when we see that P wave on the EKG, that's telling us, oh, the atrium have contracted, okay? And then there's the QRS, so look at here, QRS, the big spike, and that is telling us the ventricles have contracted. And so when we look at the EKG, it's like, oh, there's a P for every QRS because the atrium are contracting and then the ventricles are contracting. Well, that's a good thing. This is good. This is good. We like this. And then we have the T wave, and that represents ventricular relaxation because there's got to be a contraction and then there's a relaxation. Contract and then relaxation. So these T waves right there, which is right here in a bigger view, represents ventricular relaxation.
Why does it have a charge?
Why does it have a charge?
Yeah, if that's a spike. The spike indicates firing. Why does the T spike go up? Why isn't it flat?
Ooh. So he was asking, why does the T wave actually have, why isn't it just flat? Why is it an electrical conduction? Yes. Contraction and relaxation. No. So that's, thank you for that. So it's the transport of ions through the membrane is what it's measuring. That makes the electrical signal, which Does that make sense to you?
Yeah.
It makes sense to you? Oh, well, then it makes total sense to me as well.
Welcome to our lab.
And then the QT, oh, wait, let me show you where the PR is. So it's the little yellow. So look it's the P wave, right? Where's my cursor? P to the R's. There's the R's up there. They're measuring that space. So look at where the yellow is. And then the QT represents the time it takes the ventricles to depolarize and repolarize. So this is where the Q wave, so see where the Q wave is, to the T, represents the time it takes for the ventricles to depolarize and repolarize, to contract and relax. So when the doctor's actually looking at your EKG, he's reading it. He's looking at what electrically, what should be happening in your heart. And they can diagnose a lot of things by that EKG, because when things go awry, it shows up on the EKG, like AFib did. Remember Sharon showed us? And a lot of things can be diagnosed with your EKG. Okay, so let's talk about supraventricular tachycardia, or SVT. First of all, has anyone been diagnosed with it? Only one person?
I know
Okay. Yeah.
I think
Okay.
I'm not sure, I tried to look.
Yeah. Okay.
Is there a
Well, there can be a sinus tac, meaning that it's actually coming from the SA node when it's sinus, or there can be just an atrial tac, and I'll get into that. Yeah. Dodie, what exactly have you been diagnosed with?
thinking? I'm curious if what we were going to have and
That could have been your ventricular rate. Yeah. Oh, and then you got cardioverted. How are you feeling? No. Yeah. Tell us specifically, like, was it short of breath? Was it chest pain? Were you fainting? Were you coming in and out?
no, I don't memory doesn't serve me very well. I really don't know. Your friends were sitting next to me.
Yeah. Yeah. Right. You remember that cardioversion?
Oh.
Yeah. So let me share with Zoomland your story. Well, first of all, the moral of that story, always have lunch or dinner with a nurse friend. Right? They'll probably save your life. I'm just saying. Take a nurse to lunch, and there's two right here. So Dodie's story is that she was out to lunch or dinner with a friend and started not feeling well, but the nurse took her pulse and knew it was very quick, and they called the ambulance, and she was not, some of her symptoms were feeling really awful, short of breath. Were you having chest pain? Don't remember chest pain, but they hooked her up once they got her into the ambulance, and once they got her into the hospital, that's what, right? The hospital shocked you. It was in the ambulance. Yeah, so she didn't get any of those feel-good medications. She felt the whole shock. And it shocked her out of that, it shocked you out of it, right? Wow, that's quite the story.
All I can remember is
Wow. So it wasn't your time. Nope, wasn't your time. So SVT is a type of irregular heartbeat, also called an arrhythmia. It's very fast or erratic heartbeats that affect the upper chambers. It originates above the ventricles, just like Linda was telling us, you know, supra is above the ventricles. The typical heart beats around 60 to 100 times a minute. So there's a EKG strip, nice, probably 75 beats per minute on that strip. During SVT, the heart beats about 150 to 220 times a minute. Occasionally it can be faster or it can be slower, but it's quick. It's quick. So think about like what we just learned about the electrical system. So we know that something is awry, right? For it to be beating that fast. That's not what the SA node wants us to do. And so that's what we're going to get into. So there's, yeah.
So what you're saying is, so they shocked her and that resets it?
Yeah, that kind of reset it. Yeah. Yeah. It's like rebooting. Yeah. So what?
It's just so amazing.
It is so amazing. Types of SVT. So there's atrial tachycardia. Okay, good point. Because Sandra and I were talking this morning, and I misspoke and said like sinus tach, and I was like, well, wait, sinus tach. She was saying comes from the SA node if it's sinus, meaning normal sinus. But an atrial tachycardia is not coming from that SA node. It's coming from a focus of these ectopic active cells somewhere else in the atrium that are saying boom, 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 and creating this atrial tachycardia. It's not coming from the SA node. Sinus tach, yes, it would. But an SVT or an atrial tachycardia, which is a type of SVT, is like what this picture shows right here. It's just this irritable area in the atrium that have these active cells. So let me just share this from Paul. Purkinje, oh, I just lost it. Can you read it?
Yeah, so Purkinje fibers is named after Jan Evangelista Purkinje, often angelized as Purkinje, a Czech autonomous physiologist who described the fibers in the heart's conduction system in 1839. The cerebellar Purkinje cells are named for him too.
How in the heck did they know that in 1839? That's crazy. Are you happy now?
More happy than I was.
That's
But I still wanna
crazy.
know what the his thing is all about.
Well,
It could be a hers or a theirs for it.
oh, we'll have to look that one up too.
Gender
We'll put
related-
Paul on that as well. Gender. He, they. No. Okay, so that's atrial tachycardia. There's other types of SVT. There's one called AVNRT, which is, let me move this. Atrioventricular nodal reentry tachycardia. So this is probably one of the more common SVTs. And what happens, and I'm going to show you an animation, because I think the animation really explains it much better than these still photos. So there's a small short circuit near the AV node between the slow pathway and a fast pathway. where that conduction comes through. And what happens is the conduction goes down maybe that slow pathway, but the fast pathway is still open and it will kind of just re-enter that way. And it's kind of this repeating conduction that causes that conduction to go down the bundle of his and those Purkinje fibers. Let me see if I have oh no. Okay, so it kind of, the animation will tell you a little bit more why the EKG kind of looks like it does. And I'm going to save it for the animation. Oh yeah, yeah.
So far, it's only been showing it in the right atrium. I assume the same thing happens on the left.
Well, that's where the AV node is. But wait, it's like, oh, look, it's happening somewhere else too. And this is another type of SVT. It's AVRT, and it's the atrioventricular reciprocating tachycardia. And this is just an accessory pathway, not in the right atrium. I mean, this one, as you see, it originates right here. And it's a large circuit between the normal wiring and an accessory pathway. And so this extra pathway is now just taking control and making sure those ventricles contract. So it's not always with the AV node.
The P and the T waves joining the
If it's fast enough, yeah.
TMI.
That was funny. That was funny. Okay, so here is an animation that's gonna hopefully put it all together from the normal electrical conduction to all these funky SVTs. So yeah, cardioversion.
That was done. Did it matter, this kind of thing?
I don't think so. And I'm going to defer to Sandy. The fact that you were not feeling well and you were probably decompensating, meaning going down, not doing well, that the most important thing is getting you out of that rhythm. Yeah. Now, if it's not an emergency, it does matter where some of these originate from, depending on what they choose for treatment. And I'm going to get into that.
Supra-ventricular tachycardia.
Can they hear it on Zoom? And could you guys hear that? Okay.
The caption thing blocks out.
Yeah, I'll make it bigger.
SVT refers to rapid heart rhythms that originate above the ventricles in the atria or AV node. It's also called paroxysmal supraventricular tachycardia for its episodic nature. The rhythms come suddenly and go spontaneously. In normal conduction, electrical signals are initiated in the SA node and travel throughout the atria to reach the AV node. The AV node is the gateway to the ventricles. It delays the passage of electrical impulses to the ventricles to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. This refractory property of the AV node is essential in limiting electrical activities that reach the ventricles. It keeps the ventricular rate, hence heart rate, in the normal range of 60 to 100 beats per minute. SVT occurs when abnormal electrical pathways bypass or corrupt the AV nodal checkpoint. As a result, heart rate accelerates and the ventricles contract before they are properly refilled. These ineffective contractions may cause lightheadedness because the brain is not getting enough oxygen.
Yeah, you need to.
By definition, SVT
The Zoom land people are not getting the video.
Well, if you click off the screen so we see you, we see the video up on the board behind you. I
Well,
can,
that's gotta suck.
well, it's better than nothing.
Right.
Can
but-
you see it now?
Let me go back to my other screen.
But wonderful sound test.
Supraventricular
Oh,
tachycardia,
thankful for that.
How about now,
it's there.
Suzanne?
It's there.
SVT, refers to rapid heart rhythms that originate above the ventricles in the atria or AV node.
Yes, I
It's
see it.
also called paroxysmal supraventricular tachycardia for its episodic nature. The rhythms come suddenly and go spontaneously. In normal conduction, electrical signals are initiated in the SA node and travel throughout the atria to reach the AV node. The AV node is the gateway to the ventricles. It delays the passage of electrical impulses to the ventricles to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. This refractory property of the AV node is essential in limiting electrical activities that reach the ventricles. It keeps the ventricular rate, hence heart rate, in the normal range of 60 to 100 beats per minute. SVT occurs when abnormal electrical pathways bypass or corrupt the AV nodal checkpoint. As a result, heart rate accelerates and the ventricles contract before they are properly refilled. These ineffective contractions may cause lightheadedness because the brain is not getting enough oxygen. By definition, SVT includes all rhythms that originate above the ventricles. In practice, however, SVT refers only to AV nodal reentrant tachycardia, AVNRT, atrioventricular reciprocating tachycardia, AVRT, and atrial tachycardia. AVNRT happens when the AV nodal tissue has two pathways with different conductivity, one slow and one fast. If an atrial impulse arrives at the AV node when one pathway is conductive and the other is refractory, it will follow the conductive pathway. However, it may circle back through the second pathway if this becomes excitable again before the signal leaves the node. If this continues, a self-perpetuating loop called a reentrant pathway may arise. With each cycle, the signal is transmitted down to the ventricles. The atrial and ventricular rates are identical, regular, and fast. AVNRT is the most common type of SVT in adults and is twice more common in women than in men. In patients with AVRT, there is an additional connection, an accessory pathway, between the atria and ventricles. The pathway acts as a shortcut to the ventricles, bypassing the AV node. It allows part of electrical impulses to arrive to the ventricles sooner, causing a so-called pre-excitation, which can be seen as a shortened PR interval on an ECG. Because part of the ventricles depolarize earlier, ventricular depolarization develops in a more gradual fashion and lasts longer, resulting in a slurring, slow rise of the initial portion of the QRS complex, known as delta wave, and QRS prolongation. However, the presence of the accessory pathway alone is not enough to cause tachycardia. AVRT develops when electrical impulses travel down one pathway, either the normal or accessory, then back up
This
via
is
the
your left
other,
side.
creating a loop
Your right.
or reentrant circuit.
The way it's up.
The frequency of this loop determines heart rate and can be very fast. AVRT can be orthodromic or antidromic depending on the direction of the loop. AVRT is more common in children.
It's the opposite of.
Atrial tachycardia is caused by an ectopic focus in an atrium and can arise from any of the three mechanisms: enhanced automaticity, reentry, or triggered. Ventricular rhythms are regular and fast. P-wave morphology varies depending upon the site of origin and tachycardia mechanism. Atrial tachycardia is common in children with congenital heart disease, but it may also be triggered by environmental factors in healthy people. Because of the episodic nature of SVT, symptoms come and go and may not be present during physical examination. ECG findings may be normal, and the condition is often misdiagnosed as anxiety or panic attacks. Assessment should include continuous monitoring with a portable ECG recording device. When SVT is caused by an underlying condition, it must be treated. Most people who have no underlying disease and have an obvious trigger may not require treatment.
Keep going.
For others, treatment and lifestyle changes can often control the condition.
Because on Zoom, what you did is you shared a specific application window.
So FYI, Zoom sucks. So sorry, Cary, I'm so sorry. So is this where you were?
No, but that's okay. I'll find that.
YouTube, put in SVT in YouTube and it'll take you straight to.
And this will be on, it's being recorded, right? Boy, is it back up for
It
them?
was never gone for them in that scenario. It was just gone to the room.
Here, click on.
Well, they, or in the beginning, they didn't catch the
Right.
video, but you fixed that.
I
That's
fixed that,
that,
and then
that's
I
that.
messed it
Okay,
up. in the
that's
room, but
so
it
when we do
was
this,
visible.
it only shares the video, and then when we do this, it only shares the presentation. So even if you click off on here, like say for example, you were sharing this, but you move to this, when you do that, it'll only show this. So you have to reshare it again like this, and then okay, we can figure that out later, but for now, let's just get this here.
Yeah, perfect. Oh,
Go to the slideshow from current slide or whatever. And this is for the room. So where were you?
okay.
Very good.
I think I have SVT. So question. From what we know about AFib, remember from Sharon's, and now what we, little bit that we know and totally confused now about SVT. Generally, what is one major difference? Like if I was to take your pulse, what rhythm or what beats or what would I feel? Or if I was listening with my stethoscope, what would I hear if you were in normal sinus rhythm? What would I,
Heartbeat.
tell me?
60 to 100.
Yeah, bump, 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 bump. Okay. Now, what would I hear or what would I feel if you were an AFib?
Heartbeat from 150 to 250.
But what would I feel or what would I hear?
Fast.
All over the place. And what if it was in SVT? Yeah. Okay. So,
Ejection fraction come into that.
ooh, wait a minute. I'm gonna,
Good question.
yeah, he wants to know about the ejection fraction, which I'm gonna get to, because that's everything. Baby shark. Okay, anyway. Okay, so if you're taking your heart rate or you're not feeling well, we've had people in here who shall remain nameless that, you know, we discover an irregular heartbeat, or maybe their heart rate is fast or something. It's not, and we can explain it away, can't we? It's human nature. We can explain it away. I didn't sleep well last night. Oh, it must be my asthma. You know, we've got a million things what it can be, but you know what? Let's just make sure it's not the most life-threatening. That's what we really want to know. And that's why if you come in here and we pick up that you have an irregular rhythm, the first thing in our head is going to be, let's make sure it's not atrial fibrillation, because there's a higher chance of stroke and heart attack and things like that with clots. Now, you can have an irregular rhythm and even be in sinus, because there's other rhythms. You can be in a sinus rhythm and then have a premature beat that will make it feel like it's irregular, but that's not life-threatening. But we don't know that. We don't know that if we're just feeling and listening, but that's why we get our little cardia out, and we'll do a little EKG so we can see if it does look like it may be AFib, or if it looks like it's whatever it is. It gives us a little bit more information. So putting it all together, and granted, 20/20 hindsight, right? We all are brilliant when we're looking back, because at the time, you know, just kind of think about it. Take your own inventory. Are you short of breath? Are you dizzy? Or did you get up and go, got up and went? Like, what have you been feeling? That, along with any of these irregular rhythms, should be a red flag. Either you calling your doctor, or if we're catching it in here, we're calling your doctor for you, or we're calling the ambulance, or you're calling 911 at home. It's not something to ignore, right? Listen, there's nothing better. Now, this isn't what you typically think, but there's nothing better than to go to the ER and for them to say, it's nothing. That's what you want to hear. Instead of, it's a good thing you came in because you were this close to dying. You know, it's like, oh,
They didn't tell me that. They said, get the second suite open.
get the what?
The second suite open.
And what does that mean?
They were taking me up to put in a stent.
To the cath lab.
They didn't tell me I was close.
Oh, they just
called ahead.
You
and
did
said,
not pass go. You did not collect $200. You went straight to the cath lab.
Yep.
Yeah.
Express train.
Express train. So it's so easy for us. This is what the point I want to bring up. It's easy for us to explain symptoms away. But if we know we have a cardiac history, or if and I'm going to talk about risk factors, if we fall into that category, we need to take our bodies seriously, and we really need to tune in. And that's why we do these type of lectures. The more you know, the more proactive you can be in your own health, and the less likely you will die at home. And isn't that kind of the key here? You know, we don't want to die at home. Yeah.
How does the blood pressure react and something like that?
That's a good question. And I'm going to kind of get back to what Tom said as well. So in fact, I think I have a slide on this. Let me see. It's coming up. It's coming up. Okay. So let's talk about risk factors for SVT. So any type of heart conditions, especially congenital heart defects, like if you're born with something in your heart, that can be a predisposition for having SVT. Having heart disease, coronary artery disease, heart valve disease, and other conditions can elevate the risk as well. Heart failure. When you think about heart failure, kind of the whole structure of the heart kind of changes. That's the remodeling of the heart. And with that comes arrhythmias, and SVT can be one of them. Previous heart surgery. So think about this. So I used to work on a floor that we would get everybody that had coronary artery bypass surgeries. That's when they saw open your chest and they take a vein from your leg and they bypass the blockage on your heart. So if there's any type of heart surgery, there's a chance that that electrical conduction pathway can be cut, can be nicked. If you have a heart attack, depending on where that vessel that's blocked, that is no longer providing oxygen-rich blood to a certain part of the heart, it could be part of the conduction system. all of these things are gonna put you at a higher risk of having SVT and other issues like that. Being female, okay, we are the superior species, and with that comes what?
What he
Comes more responsibility. Yes, but we're not complaining. So being female, SVT is more common in women than men, with female to male ratio approximately 2:1. This increased prevalence is particularly noticeable with AV-NRT, the most common type of SVT. So let's talk about some lifestyle risk factors. So, you know, if you're using drugs or drinking a whole bunch of alcohol, this can trigger SVT, like things like cocaine and methamphetamines. Not good for the heart. So please, everyone, stop doing cocaine, okay? Smoking, just tobacco itself or even cannabis are a risk factor as well. Caffeine, no, I love caffeine, but excessive amounts can, like coffee, tea, and other sources can be a trigger as well. I know Sharon said that caffeine wasn't meant to be a trigger for AFib, though she said her own experience was when she drank coffee, and now she's not drinking any coffee or it's decaf, that she's much better controlled.
What's excess?
Good question, because for high blood pressure, we say, you know, not more than 200 milligrams of caffeine a day, which is not much.
How does that translate into a cup of coffee?
Cup of coffee is like anywhere from 1 to 150. So like a cup or two, yeah. And you know what? The ER visits have gone through the roof with the introduction of Red Bull and any of those caffeinated drinks that young people drink. And ER visits go through the roof because they go into these techie rhythms. Crazy. Stress and anxiety. High levels of stress and anxiety can contribute to SVT. Okay, other factors. Age, dang it. We got to find the cure for aging. And when you do, please share it with us, please. While SVT can occur at any age, it's more common for older individuals. As the heart gets older, structural changes happen. Pregnancy, and when women are pregnant, your cardiac output becomes greater. And SVT is also known to occur with pregnant women. Certain medications like digoxin and theophylline, I haven't heard theophylline for such a long time. You remember that back in the day? It can trigger some cases as well.
She's an asthma.
Yeah, back in the day, back in the 80s. Okay, so yeah. So what do you feel? Okay, so let's talk about that. Like, what's happening? I thought I had a slide, but what's happening in the heart when your heart is pumped? I do have a slide, but I'm going to talk about it now. When your heart is pumping that fast, what is happening? How well is the atrium and the ventricles filling with oxygen-rich blood? Minimally. And when it gets pumped out of the heart, where's the first place it goes? To the brain. And so if you're not getting oxygen-rich blood to the brain, what are you feeling? Dizzy. You're going to pass out. You may be having chest pain. It's all about getting that oxygen-rich blood to the parts of the body that it needs to go to. So you're going to feel that rapid heart rate. You're going to have chest pain. You're going to feel tired, overwhelming fatigue, that lightheadedness, sweating, feeling dizzy, maybe passing out, palpitations, shortness of breath. It may be mistaken for a panic attack as well. And these symptoms may range from mild to severe. And as I was making this slide, you know what? All of these symptoms are the same for AFib. So basically, if you feel like crap, do something about it. Make an appointment, go to the urgent care. If you're in here, speak up. Because your body's telling you something. And we need to listen to our bodies. The last thing we want you to do is to have an issue or to die at home. We certainly don't want any issues in here, but we'd rather be ahead of the game and make sure nothing does happen in here. So let us know. Oh, here we go. This is it. Okay, yeah, Marjorie.
It's so easy to rationalize
100%.
with something you're familiar with. like
Yeah.
asthma, 30%.
So it's like a piece of the puzzle. Okay, well now I'm a little bit older, you know, now I'm in my 70s, or maybe now I'm in my 80s. And I do have some of these risk factors, and maybe I should just get checked instead of rationalizing, because the consequences are too great. So why do we have those symptoms? So when the heart is pumping at a very fast pace, the chambers do not have time to fill completely. So not enough oxygen-rich blood is getting pumped out to the major organs like your brain. Yeah, nothing's working then. It's all falling to pot. Okay, so how do you diagnose SVT? Well, let's do a blood sample first, because if there's something going on with your thyroid, that could very well be causing a fast heart rate. And let's do an ECG. And remember, if you're in SVT, it's going to show for sure on your EKG. But like Sharon was saying, our smartwatches can pick it up, which I think is fascinating. We had that little Cardia, which is just 2 fingers, and I think you can get those up. Can't you get that off of Amazon?
Cheaper, $80.
You can get that little Cardia, which is probably a little bit more, well, I don't know that, but it's another way to look at an EKG of what your heart is doing.
That's a commercial consumer advice. Like the Jeff Rogan, it's just a brand like that. Yeah, they're easy. They're easy to get. So it's a good purchase to make. If you have heart rhythm concerns, sure. And it's linked to your smartphone. So your phone is what basically where you get your images and your pictures and stuff.
The Cardia is linked to your smartphone?
It's linked to a device, and it could be your phone.
Got it. Got it. So I think we have the technology available to us. And if you do have issues, like I don't have issues yet, so I don't know that I would do it. But if you have a history of having arrhythmias, certainly would not be a bad purchase. Or at least having your smart watch hooked up to look for AFib. Holter monitor, that's another way. Who in here has had a Holter monitor? And now they have changed so much. Do you remember back in the day when it was huge and you had a million electrodes and you couldn't take a shower? Now it's just this little patch, right? It's pretty cool. And you can wear the Holter monitor for a few days or a few weeks, and it will pick up any irregular heartbeats that maybe are happening, but they just can't catch it with the EKG when you're in the office. And then there's event recorders, and this device is like a Holter monitor, but it records only at certain times for a few minutes at a time, and it's typically worn for a month. And you usually push a button when you're having symptoms, or the device will automatically record when it detects an irregular heartbeat occurring. So like if the Holter monitor that you wore for a couple of weeks didn't pick up anything, but you're still having occasional symptoms, maybe an event recorder will be the next thing. Or an implantable loop recorder, and this device records the heartbeat continuously for up to 3 years. It's called a cardiac event recorder, and it shows how the heart is beating during daily activities, and that data can be retrieved and sent to your doctor's office. It's pretty amazing. Yeah.
Tiny, tiny microchip they inserted into my left brain. And then there was a phone by my bed, and it recorded me for 2.5 days. And if anything was off, they were calling me.
Yeah.
I don't really,
Do you still have the chip?
well, the doctor called himself and was interested in, removing it, and I found out that that was just really an unnecessary surgery unless I was having problems with it. I don't even know it's there.
Okay, okay. So we have someone in the room that actually had an implantable loop recorder for 2.5 years. And well, yeah, she still has the chip. She refused to have it removed. And I think they're probably recording your thoughts at this point.
They'll think it's broken.
Oh my goodness. Other ways to diagnose SVT, an echocardiogram. That's just like an ultrasound, and it can see if there's structural changes, whether you're going to be more prone to SVT or if you're actually in SVT. It can look at how the blood flows and your heart valves. And then an exercise stress test, which could trigger an SVT or even create a worsening SVT. Whether it's on the treadmill or the bicycle, your heart activity is checked. If you can't exercise, then there's medications that they can give you that makes your heart race like it is exercising. And they can determine a lot of different things just from that test itself. And sometimes they do an echo during those stress tests as well. And then also a tilt table. Has anyone had a tilt table test? It's hard to say 3 times fast. This test may be done to learn if a fast heartbeat leads to fainting. Your heart rate, your rhythm, blood pressure are checked while you lie flat on a table. And then under careful supervision, that table is tilted to a standing position. And it's going to look at your heart rate, at your blood pressure, in your rhythm, and see what happens and whether there's some nervous system issues involved with it that responds to changes in position as well. And then the EP study, and Sharon talked about this, that EP study, it's done kind of like a heart catheterization, and they're mapping out the heart to look for some of those irritable spots that could be causing that SVT. And then through that EP, they can then do like an ablation. Oops. So treatments. Okay, I'm telling you one treatment, and I'm going to make you all sign a paper because you can't do this one at home. It's a carotid sinus massage. Do not do carotid sinus massage on your own. Right? Does everyone understand that? You don't even know what it is. And I'm telling you, don't even do it. What?
Pro wrestlers do.
Pro wrestlers do it?
Yeah, saw it back in the 60s.
Okay, so,
They flop down after 30 seconds.
okay. So your carotids are these big vessels that come right off of the aorta, go straight up to the brain. And if a professional medical person massages that for a fast heart rate, certain chemicals are released that can, or is stimulated to slow down that heart rate. Here's the thing. We have people doing this and then they pass out, right? Because you're occluding blood from getting to the brain, right? It's not something that normal people should be doing. Only healthcare professionals should be doing it. Carotid massage should only be done by experienced healthcare professionals. So who's going to do this at home? No. I don't see anyone with their finger up to their neck. Good, good, okay. Vagal maneuvers can help with fast heart rates. So simple but specific actions like coughing. Like if you feel like a fluttering in your chest, just it like increases intrathoracic pressure, and that may stop a fast heart rate. Or even like bearing down, like if you're having a poop. Some people pass out from that, but that can also lower a heart rate. You got to be careful now if you're prone to fainting. We don't want you doing that. Putting your face in ice water also can slow down heart rates, but all of this is stimulating the vagal nerve, which can make you also pass out. So we don't want that. Any questions? So medicines also. So SVT happens frequently. Medicines may be given to control the heart rate or reset the heart rhythm. It's very important to take medicine exactly as directed in order to reduce complications. And then what Dodie had done, the cardio version. So paddles or patches on the chest deliver shocks that reset the rhythm. And this treatment is generally used when emergency care is needed, or when vagal maneuvers and medicines don't work, or when the patient's going down the tubes. And then the catheter ablation, Sharon talked about this, and that's when they kind of go through like a heart catheterization, and they're able to map out the heart and find out where irritable or accessory pathways are, and they can ablate it either with like heat or with freezing certain areas, so that those pathways, those accessory pathways, or those ectopic areas that are causing SVT can be frozen away. And it scars up, and that blocks the irregular heartbeat from happening. Or a pacemaker. And a pacemaker, it can stimulate the heart as needed to keep it beating regularly, and it can override what maybe is an SVT. Pacemaker is placed under the skin near the collarbone. It's minor surgery, and those wires either attached to the heart, or now there's little pacemakers that are just put directly into the ventricle. There's no wires involved. It's quite crazy and amazing what the technology now for pacemakers, for any of these treatments. I can remember ablations where it was, Sandra, remember, it was the kind of, before they were mapping, and they would go in and ablate where they think might be, they would try to elicit a certain response from the heart, like get it into SVT, and oh, I'm going to ablate here and there. And sometimes if they would ablate too much and no electrical stuff would get through, you woke up with a pacemaker. Oops, sorry. But now they have the technology to just map the whole heart, and so they know exactly what they're doing. It's pretty amazing. Okay, so what are your takeaways from today's talk? What will you do if you notice a fast heart rate and you have symptoms? What are you going to do? Go where? Going to go to the doctor. Cough. I like coughing. What else are you going to do? What if you feel like crap? And you didn't, you're not eating lunch with a nurse. You're going to call 911. Yeah. Because what's happening in your heart, whether it's AFib and it's just very fast, or it's just a very fast heart rate, you don't know what it is, but you know something's not right, and it feels, you don't feel good, and it feels like there's something going on in your chest, you don't know what it is. We know that those symptoms are telling us that not enough blood is getting to our brain. That's what it's telling us. And so, number one, the one thing you don't do is ignore it. Because it's so hard. It's what we want to do. We all do it. And so we're just telling you, don't do that. It is hard, but the life you may be saving could be your own. Yeah.
Is this something that's gonna happen all at once, or is it like there's gradual signs that?
I think with SVT, you're either in it or you're not. And kind of the same with AFib. And remember what Sharon said, that these pathways, the more you're in it, the more stronger that they become, and they become the dominant pathway. And then it's harder and harder to get out of. So we want to get ahead of that so it doesn't become something permanent. And then more aggressive type of treatments need to be done. Getting this PowerPoint already, I found a really great article. There's the DOI, but I also have it printed up here if anyone wants to see it. I got a lot of the information. It's really a great article, just if you wanted. And I'm done unless there's any other questions, but I do have a really fun video that I want you guys to see. But are there any questions, or what questions do you have for me? Yeah.
Had to be person from the company that made them in the surgery, guiding him.
Yeah. I think that still happens. It's the rep. The company rep are amazing people. Like, they're telling the surgeons exactly. It's pretty amazing. Could have been. Yeah.
They were using a new
Yeah, the Cary. Yeah.
There were a lot of people.
Yeah. Well, listen,
Everybody introduced themselves.
you want someone knowing what they're doing. Yeah.
Have them sign in, please.
What?
Have them sign in.
Tom,
Kind of makes you wonder what all this poking around in your heart is doing.
saving your life? Well, they're only poking around in your heart if it needs to be poked. Right? They're not poking for fun. No one pokes for fun.
Anymore. 1839, you know what I'm saying?
Okay, do you guys want to see kind of this? It's
Okay.
ancient. This video is from the 90s. Yeah, probably before the 90s. And it's just, you'll recognize some of the rhythms. But oh shoot. What just happened?
Stop your share, did you?
Thank you, Cary.
Thanks, Tom.
Ejection fraction measures how the blood goes out of the ventricle.
Yeah, how much blood and what the force is. Yeah.
So you're not sharing it, though. You just
Oh,
share.
okay, here, will you just get it set up?
Are we coming up there? Not there. This one?
No, you're the other. You're the other.
This one?
Yeah.
And it really isn't any sound for this. So it's this man's doctor. Remember the atrium, you know, them.
Atrium. That's normal sinus rhythm. And then this is premature atrial contraction. That one came.
Maybe see that it should be some ventricle.
First degree heart block. That's there's a delay. Fifth degree heart block. That's very
The delay between the atrium and the ventricle. That's what's called.
And we know where the right bundle is, right?
Again, you're not gonna feel it. It's your ventricle level.
He's getting yeah. Cluttered. Smell like pizza.
There's more room to the third feet into the space.
And then there's AFib.
So the atrium are go whacking and doing all kinds of stuff. Every once in a while, that's pretty good.
Yeah. Very irregular. Okay, now here's a whole series. CBC, the DPAC, another step. There's CBC.
There's a bunch of people. I can see that. Of course, you can
That's
see
big, big, big. She's gonna get shocked. And he got back inside the rhythm. Oh, here's the unsuccessful. And he said, successful rhythm. He didn't make it.
Living arrhythmia, that's called, yeah. Living arrhythmia. So now, when Oh. Well, we could look it up. Sandra can tell you, she's looking at it. Sandra, what year is it from? And I think we're done, right, Karen?
Yeah. Thanks, everybody. You want to sit here?
Yeah, I wish those playing videos went better with this. So I think what happened there is when I turned it back on, I picked the wrong one from here, like Arjen was showing you. Yeah.